Hello, everyone. My name is Shad Rayed from Detroit Medical Center, and this is Heart Trending. With me is Dr. Lina Ya'qoub. She is a General Cardiology Fellow at Louisiana State University, Oxnard Medical Center. Welcome, Lina, to the show.
Thank you so much, Shadi. Thank you for having me. It's my pleasure.
Lina, you have been doing a phenomenal job in terms of staying up to date with the literature as well as with your busy schedule as a fellow now. And welcome to the interventional award. Next year, you're going to be an interventional fellow at Henry Ford, so congratulations.
Thank you so much. Yeah, I'm actually super excited about it. This is one of my biggest dreams.
Lina, thank you for agreeing to be on the show, first of all. And second, we have discussed this before. There is a lot of great trials and studies presented at the American Heart Association. One of them was the River study. And the trial was very interesting because it touched a very important aspect in clinical practice related to mitral valve bioprosthesis and anticoagulation. So first of all, I would like you to share your thoughts and the data, and then we have a short discussion about it.
Yeah, of course. I myself have a special interest in this topic. First of all, we have knowledge gaps in this, the optimal antithrombotic regimen for bioprosthetic valves. And I'm also interested in structural heart disease. So this is something that I was looking forward to hear the results of the study. So the River trial is actually a randomized clinical trial that looked at rivaroxaban versus warfarin in patients with AFib or aflatted and bioprosthetic mitral valve. And the background and rationale, why is this trial so important, is that we actually have very limited data in this specific population. Very limited data from trials. One of them is the Aristotle trial, which looked at apixaban versus Coumadin or warfarin. And as you can see, the number of patients who met the inclusion criteria with mitral bioprosthetic valve and non-AFib was only 31 patients from 18,000 or more patients. Same for Engage TIMI 48 trial, which looked at edoxaban. Again, these patients were only 131 patients out of more than 21,000 patients who had mitral bioprosthetic valve and had AFib. So the River study was designed for that specific reason. Patients were actually enrolled from 49 sites in Brazil to two arms. One is rivaroxaban, 20 milligram daily. They gave a reduced dose of 15 milligram daily for creatinine clearance from 30 to 49 ml per minute. Obviously, creatinine clearance less than that was excluded from the trial, versus Coumadin, and the INR target was 2 to 3 inclusive. It was a non-inferiority randomized clinical trial, and the primary endpoint was death, major cardiovascular events, and or major bleeding. The major cardiovascular events, just to mention, they looked at the stroke, they looked at TIA, valve thrombosis, systemic embolism, and hospitalization for heart failure. And so overall, they had 1,005 patients. 500 patients were randomized to the rivaroxaban group, and 505 was randomized to the Coumadin or warfarin group. What is important to note here is that the percentage of time that in the warfarin group that was in the therapeutic range was only 65% of the time, meaning that there is almost a third of the time those who were receiving Coumadin, it was not therapeutic.
Well, as you said, Lina, this is a very difficult cohort of patients. They have not just valvular heart disease, but also arrhythmias. Mm-hmm. But this speaks to the challenge of controlling INR in this cohort. Even in a randomized trial where there is a phone follow-up, where there's face-to-face follow-up, still they could not maintain a therapeutic INR, either below or above, which can increase the bleed or can increase the risk of thrombosis. which is this is kind of enough said about the challenge of managing INR in these patients before even considering the second R.
Exactly. Yeah, I agree 100%. I had the same thoughts. So looking at the baseline characteristics of each group, really they had matched these groups for baseline characteristics. I wanted to point out that females were around 60% of each group, which is great. We don't see this often in clinical trials. Yeah, and this is something we would love to continue to see. Now, looking at the primary endpoint, and as I mentioned, in this trial, they really wanted to look at the event-free survival time, or the restricted mean survival time. And at the end of 1 year, they noticed that there was a 7.4 days survival time longer with rivaroxaban compared with Coumadin. They also analyzed these results based on the intention to treat and the per protocol and as treated. So the intention to treat definitely met, the p-value definitely met the non-inferiority, but superiority didn't meet based on the p-value. And the secondary efficacy endpoints, there was really no difference between rivaroxaban and warfarin in all secondary endpoints. I want to point out that total stroke was actually lower with rivaroxaban compared to Coumadin with a p-value of 0.03, so that is significant, but it was mainly non-fatal stroke. And for safety events, the bleeding events were really also again similar between rivaroxaban and Coumadin. It's important for me to note or to say that intracranial bleeding and fatal bleeding were actually zero in the rivaroxaban. Two things: the antiplatelet at baseline, and that's very important. A lot of patients are on of our patients are on antiplatelet at baseline. They actually found that with rivaroxaban, the RMST was actually longer than Coumadin, meaning that the event-free survival was longer and it was significant. Similarly, time from mitral valve implantation, if it was done within 3 months, the rivaroxaban had an RMST that was much longer with 348 compared to 313 in the warfarin group. So these two subgroups, the antiplatelet at baseline and mitral valve implantation within 3 months, actually the rivaroxaban group did better compared to Coumadin. And this is just to illustrate that the RMST difference in patients who had mitral valve implantation within 3 months was actually 35 days. So in conclusion, this trial showed that in patients with AFib or A-flutter and a bioprosthetic mitral valve, rivaroxaban is inferior to warfarin with respect to mean time free from death, major cardiovascular events, or major bleeding. Since rivaroxaban does not require monitoring, has more consistent anticoagulant effects, less influenced by food and concomitant medications, it may represent an attractive alternative to Coumadin in certain populations.
All right, thank you, Lina, for the great presentation. This is exciting, as you said, study that's going to help a lot of patients, especially who has multiple comorbidities we see on daily basis. As you said, there is the main takeoff for me is the inclusion of majority being women. And number two is the fact that only 65 had therapeutic INR. So to be honest with you, that's an eye opener. Third was the higher stroke in the warfarin. So I wasn't expecting the rivaroxaban to be superior, but the fact that there is less bleeding and less thrombosis compared to warfarin, and less bleeding compared to warfarin, this is for sure a great result and blockbuster for the medication.
Definitely something we should look at and consider and discuss with our patients, hoping that we'll see more trials looking at this, and like you said, different valves, different medications, another type of DOAC, and see where where this will end up. Also, one more thing is maybe we're seeing more advances in the valve itself, right? Like
Yes,
the material of the valve itself is, we're seeing more durable valves. Maybe we'll see with these valves less valve thrombosis anyway.
absolutely.
So I think it's all of it is very evolving, and in the next few years we might see just a whole new generation of valves, whole new generation of medications that we were not used to,
Absolutely.
or we hadn't seen before. Yeah.
Thank you so much, Lina, for your time. Really, I enjoy talking to you and discussing very, very important trial. And
Thank you.
good luck for you for finishing the fellowship. And also welcome to Detroit soon to join the team at Henry Ford to be interventional fellow. And I look forward to you to be a new leader in the field of interventional cardiology and a colleague that we're going to continue to work together.
Thank you so much for your kind words and encouragement. It does mean a lot. Thank you. Yeah, I look forward to coming to Detroit and starting my interventional year. I hope I get a chance also to work with you in person one day. And I hope you have a wonderful rest of your day.
Thank you, Lina. Appreciate it.